Since Chef joined us, we'll go ahead and get started. Okay, again, we're talking about inflammatory disease of the spine. So what do you think of this case?
Okay, so what is it? 77 years old female, mild fever, past history candida. So sagittal lumbar spine. So I see there is abnormal increased single intensity on 5, 4, 3, 2, 1, T12 with some depression of the superior end plates and also some increased signal within the disc space within the disc. So
okay, so let's go back here. This is 2/17/2012, 4/16 through 2012, and then here we have 2/17/2012.
Okay, so now it's like almost complete. This one is the which one is the earlier one? The two. This is 2/17, and then
2/17
and 4/16. Okay. So 2/17. Okay, so it's like a complete vertebral involvement with. So most likely it's osteomyelitis with some epidural extension and collapse of the vertebra.
3/16.
3, 2. Yeah. So it's extending to the next level.
4/16.
4/16. Yeah. It's extensive pores. It's paraspinal muscle also. Paraspinal area also involves psoas. I mean, not psoas.
Yeah, so this is all Candida spondylitis.
Okay.
Extending. Yeah. Okay.
11-year-old, 1 month of severe back pain. And is that a contrast enhanced at the end there on the right? There's a focal lesion.
Yes.
It's got surrounding sclerosis, so it's probably a chronic lesion, and it has fluid inside of it. Looks like
You're talking about this?
Yeah, on the first image, it looks like some sclerosis around it. Looks like a chronic abscess. Yeah, and that too. Yeah, that one on top maybe a little more acute. Yeah, it's like a rim enhancing collection.
It's actually all in this collection.
Oh yeah, wow. Also enhancing. Well, that's not, yeah.
So that was a Brody's abscess in the spine that decompressed into the epidural space.
Okay. Now, do you mind going back to the sagittal? This is a question I had on another one I had of this. So you showed us one of an abscess in the epidural space before, and there also I didn't really see so much of a collection as just soft tissue, like enhancing soft tissue. Here you called it a collection again. Is there fluid in there that I'm missing in the epidural space? I mean, it's clearly related to the infection, obviously, but what is that stuff? I mean, it's not an actual fluid collection.
It's fluid and inflammation. It's an abscess.
Yeah, okay, well, inflammation. Inflammatory tissue.
Okay. Shiv, what do you think of this case?
73-year-old man with slowly progressive back pain. So it looks like one of the upper lumbar levels, there's hyperintense signal in the disc space. And it seems to be sort of extending from the disc space into the left paravertebral area. Looks like a collection. I'd be worried about an abscess in the disc, maybe.
Yeah. So that was an abscess, and not a lateral disc extrusion. Okay, Thomas.
So I have two sagittal views of the spine, and there is erosive changes at the end plates at L4, L5, with edema at the adjacent vertebral bodies, and the disc has increased signal also.
Yeah, so in the very early days of MR, it was noted that on T1 weighted images, if you lost definition of the end plates like we see here, and you could often see it again on the T2s, that was highly specific for infection. So, and then here we can also see a lot of edema on both sides of the disc space, these erosions, and then a lot of soft tissue edema back here as well.
And post-contrast, there's diffuse enhancement at the vertebral body, surrounding soft tissues, the iliopsoas muscle, paraspinal muscles. And so I think this is a month later.
Well, let's see. So we go back here. We started out on, 5/3/07. This is 6/25/07.
Yeah, I think there's more increased destruction. I think it's involving another vertebral body now too. So it's extending inferiorly. And there's still a lot of enhancement around the vertebral body.
Yeah, so this is all osteomyelitis. And even on treatment, you can get some progression until the disease is finally corrected.
Okay, 70-year-old male voiding difficulty, back pain. Okay, there's like a slightly increased signal of the L2 and L3 vertebral bodies. Yeah, those two. There's like an epidural collection adjacent to that, which is enhancing. So, okay, there's an abscess in the left psoas muscle as well, and also on the right side. So, yeah, okay, we have discussed this osteomyelitis with paraspinal abscesses.
So these generally are thought to usually start in the end plates, extend into the disc, and from the disc extend out into the surrounding soft tissues and the psoas muscles. But some people believe they can start in the psoas muscles. But here on both sides, this almost certainly started in the end plates and went onto the discs and the surrounding soft tissues.
And so 75-year-old female back pain for several months. So epi and lateral B of the lumbar. So 5, 4, 3, 2, 1. Probably L1, 2.
So a lot of osteoporosis,
right.
Compression fractures.
Right. So multiple sagittal views. So 5, 4, 3, 2, 1. So L1, 2 abnormal signal with epidural, phlegmon.
So 1, 2, and 3 vertebral bodies are all abnormal.
Right, with large area of epidural collections back, which is enhancing. So epidural abscess. So some collapse, vertebra, epidural. Anything in the soft tissue. So mostly within the disc and the vertebral body and epidural area, and some phlegmon around the vertebral body. CT, multiple levels collapsing, vertebral bodies.
So what do you think is going on here?
So multi-level, so TB.
Okay, good.
"50-year-old back pain, several months." This looks like there's a lot of soft tissue around the vertebral body, and depending on where we are, this could be just a really badly collapsed vertebral body and fragments. Yeah. Oh, that looks like a met, but I guess it could be infectious.
But we don't see it in the inlay very well.
Yeah.
It could be just destruction of the vertebral body.
Yeah. Well, there's extending into the posterior elements as well. The pedicle involved on the right. Yeah. Okay, so there's extensive involvement and some
multiple levels of 3 up here,
yeah.
2 down here.
Yeah.
We've got all this
soft tissue maybe anterior.
Soft tissue collection. And then we've got a lot of involvement in the compression of the inferior cortex here.
What is this, later on or something?
It's all the same time.
Okay. All right. Well, again, it could be just this looks like multiple bone involvement, infection. Yeah.
Again, this is multiple levels. You have all these external collections.
That's QTB as well. Yeah.
Hey, Shiv?
A 61-year-old woman with lower back pain. So it looks like on the sagittals we're looking at the facet joints of L3-4 maybe. And it looks like there's a fluid collection there and some ill definition of the facet joint, maybe some destruction of the joint. And
so here we're on 8/17/12. Here we're now 9/12/12.
Okay, so a few weeks later, and it looks like there's a growing abscess originating from the left facet joint there.
Yeah, again, this is TB. Okay. Thomas?
66-year-old female, CRF, chronic renal failure, diabetes, back pain. So we have AP and lateral views of the spine, and I guess.
So this is on June 24th. Here's August 14th.
Yeah, there's depression of the superior end plate at L3.
So if we go
loss of vertebral body height.
Here's L3, and you can see a little bit of lack of definition there. But a few months later, it's substantially worse with some compression, and still a lot of irregularity in the end plate here, as well as maybe the inferior end plate above it, and the superior end plate below it. And here's the MR scan.
Yeah, there's a marrow replacement of L2, L3, and L4. There's increased signal in the discs, especially at L2, L3. And there's perivertebral phlegmonous change. There's a lot of phlegmonous change around the spine.
Yeah.
And
involvement of the psoas muscles. Here's the
right. Yeah, it's like fluid collections in the spinal soft tissues. So yeah, this is like.
So this was aspergillosis.
Okay.
Yeah.
Okay, we have abnormal signal involving the end plates and discus space at L5S1.
This patient had recent surgery.
Okay, in the back or okay. So I don't see post-op changes at this level. Post-op changes at this level, I don't.
So on the T2 we can see definition of the end plates.
Yeah, on T1 we lose it.
At this level anyway. Again, that's very suspicious. We have loss of the fat signal here, and this was a post-op.
This kind of
disc.
So isolated root enhancement.
So this is post-contrast, and we can actually see enhancement of the root here.
Right.
So what does that represent?
So it's a multiple differentials. You can have infection, inflammation, post-op.
But infection usually involves more than just the root.
Right.
So one time people looked at this and they thought this indicated neuropathy and an abnormal nerve and a potential source of pain.
Right.
We've since found out that this enhancement is quite common, even in people who don't have symptoms, who are getting it for other reasons. So at this point, it's kind of unclear as to what enhancements means along the root like this.
Post-op, you can have it, without this kind of benign stuff. Right. Don't do much.
Epidural anesthesia. Okay. Well, the nerve roots here look diffusely kind of thickened, and is that last one an enhanced image on the right?
Probably, I think so.
And enhancing. So here I would think more along the lines of like arachnoiditis.
But they're awfully thin. Arachnoiditis,
oh, they're thin?
Get a lot of irregularity and clumping and so forth.
Okay.
These are the sagittal. Let's go to the axials.
What is kind of clumped there looks to me like?
So on the axials, you see this is very clumped. This is someone who had epidural anesthesia and developed chemical arachnoiditis. So you're right. This patient. And then here we can see the clumping of the nerve roots up here. Okay, Shiv.
Okay, again, the nerve roots look fairly clumped and thickened, especially, distal to the conus there, and sort of off to one side, eccentrically located. It looks like arachnoiditis.
So another arachnoiditis. Good. Thomas.
So we have a sagittal view. I think there's some clumping of the nerve roots also at the of L5.
Yeah, they look kind of thickened. If you go to the axial images, this is what it looks like.
Yeah, they're all thickened and displaced to the left.
And go down below, it looks like you have a cord extending down there. But that, again, is clumping of the nerve roots. More inferiorly, we can see that they're still clumped way down here. And so this is just another case of arachnoid adhesion.
Okay. 57-year-old male with low back pain and lower extremity numbness, status post-disc injection in 1973. Okay, there is complete loss of disc space at L4, L5 with mild retrolisthesis of L4 over L5. Post-injection. So it might be, okay, and we have, that thickening, all that thickening and abnormal signal of the cauda-equina nerve roots. Another case of, and there is like, thickened, some of the nerve roots are thickened, they're kind of like clumped, and we have that fluid embedment.
So this is chronic arachnoiditis, and this is actually ossification of that. So these are arachnoid ossifications from long-standing arachnoiditis.
Okay, so multiple sagittal images. Lots of changes in the soft tissue. So within the interspinous area.
So this is a facet joint here. This is a facet joint. So that's just a facet joint infection.
T1 on the left and T2 on the right. Looks like focal marrow replacement in 5, 4, 3, 2. And I don't think that we're seeing the superior end plate too well. Maybe it's still discontinuous, questionable. It's not degenerative. That's
215. Yeah. 2 weeks later, that's the bone scan.
Okay. It's not helpful, but I mean, if we only had this, I would say do an MR. So we have the MR. I mean, it's not degenerative looking, so I would want to look at the MR after this.
Okay, so that's 3-1. Now we go to 328.
Okay, so it was infection, and now it's extending to the adjacent bone.
5, 6.
Yeah.
And that was just infection. So we go back to this is the typical way these occur. As I said before, you tend to get hematogenous spread to the small vascular spaces near the end plate. that starts the osteomyelitis at that point. And then if you wait, it's really involving the joint space here. It's extended into the joint space all the way across. And here's the typical appearance of discitis or an infected joint space. But notice it started out in the vertebral body. It doesn't really start out on the disc because the disc isn't vascular, so the organisms aren't going to get in there unless you stick a needle in it or do surgery, in which case it can start in the joints, in the disc space. And then we can see the typical progression. Once the organisms get into the disc, it spreads very rapidly throughout the disc and then goes off to the other side to infect the other vertebral body. Okay, Shiv?
Okay, 68-year-old man, back pain, recent trauma history. So it looks like there's an epidural collection sort of at the level of L4, and it's enhancing peripherally. I'd be worried about an abscess. And up top, it looks like another 2 levels have some hyperintense signal within them, the thoracic vertebral body. And here in the right psoas muscle, looks like there's a big abscess. So it looks like similarly on the axial images.
Yeah. So this was all a bacterial systemic infection, and these were different locations where they had abscesses and osteomyelitis that developed with a septicemia. Okay, Thomas?
26-year-old with severe pain at the top of his butt crack, back sweat. So we have a T1.
So it'll be a little colorful today.
I guess there's a little bit of marrow replacement at S1.
So
Not sure if that's real or, yeah. And, yeah, there's edema in the subcutaneous soft tissues.
yeah, so what's all this stuff? We go back again. So in fat people, you see edema in the subcutaneous tissues all the time, especially back here. But this person doesn't have a lot of excess fat. This is right where the pain is. So they decided to stick a needle in this, and they drained 50 cc's of pus. So this was a subcutaneous abscess.
76-year-old male with back pain. Can we see abnormal signal at 2 adjacent levels? And we kind of have like loss of the cortex on T1. And there's also involvement of the disc space. Looks like discitis osteomyelitis. Okay, and I'm not sure if that's really in the right psoas. Okay, so we have an epidural collection. There's some, I think, impression on the.
So this is just another bacterial discitis.
Okay.
Okay, so
pretty typical appearance.
73 years old, female, lower back pain, month ago. Okay, so multiple level involvement, L3 to L2, L3. Okay, again extensive discitis, osteomyelitis, multiple areas. Yeah, with the inflammatory phlegmony extending into the paraspinal muscle, all kind of stuff. They're trying to do some, probably fluid collection.
Yeah, try to get an organism.
Right.
So they're concerned about fungal tuberculosis pyogenic. And this turned out to be Candida.
Okay.
Sam?
26-year-old hockey player, back pain. There's some disc disease for sure.
11/23/09. A little bit of a narrow disc here, protrusion.
Yeah. Looks like an extrusion there. Not a lot of like canal narrowing, but there's a little extrusion.
That's 1123. You may have already seen this. We have this thing right here, right?
Yeah.
That's this.
It looks like a disc. Oh.
Here's a 12-1409.
Okay, I guess it could have been sequestered, the extrusion, although...
Yeah, so that looks like a sequestered disc. So the disc has gotten worse. Here
Okay.
it is compressing the nerve root.
Okay.
Increasing. Okay. So then the patient had surgery for this. This is here.
Okay.
This is 5 days post-op.
There's a lot of like soft tissue posterior to L4-5. Yeah, posterior L5 especially. Yeah.
Here's the area of the surgery.
Yeah, that's what I'm talking about. Some soft tissue there, epidural.
So everything's going on here.
That looks like infection probably.
Yeah, well, they thought it was post-op hematoma at that time. This is on 12/23/09.
Could be
The
hematoma.
patient kept having increasing pain, and now we're a week later. This is what it looked like.
Okay, so now it's a rim enhancing collection.
And
So an abscess.
The operative cultures came back positive. See the enhancement here. You really have an abscess collection. Okay. So they started on IV antibiotics. This is on 12/28/09, and now this is 3/31/10. So we're a little bit later. So what do you see now?
So the disc is completely destroyed. Both vertebral bodies are involved. It's worsening, I guess, before it gets better.
You can see the surrounding tissues actually look a little bit better now. And that was went back to IV antibiotics.
Hello, Dr. Cruz. This is Pablo.
Hi, Pablo. How are you? Why don't you take this case, Pablo?
Okay. Let's see. We have a 76-year-old male with low back pain and sciatica for 5 weeks. Rule out herniated disc, and the sagittal image show the T1. Looks like there's replacement of S1 and also posterior to S1 within the maybe epidural, extending the epidural space. I'm not sure if the thecal sac is invaded. It looks like it could be an infection or also a tumor, but in T2, I don't think the vertebral body is destroyed.
Yeah, so if you notice here, we lose the end plates at these two levels on the T1, but we see them fine on the T2. Again, that's very characteristic of infection. Okay. Here are the axials.
The axial shows similar pattern extending into the canal, maybe a little bit prevertebral, and the coronal looks like it's on the left side. The CT actually, it looks different on the right side, the left, but it's more actually increased in density compared to the right sacral ala.
Yeah, so
there.
Here we are.
Maybe the iliac.
This is 11608, 11608, going primarily here on the left side. This is 111108. Again, the MR scans abnormal right over in here.
Yes, I was wondering if the iliac bone was also affected in the CT. They're a little lucency anteriorly at the SI joint level, but it could be just degenerative.
I think that's just degenerative. And then here we have the 111208.
111208. Let's see, and the coronal shows again T1 hypointensity, mostly on the left side, and that's just T1 post. So there's definitely enhancement. Looks like osteomyelitis is not healed. Looks like maybe worse. I think the prevertebral, presacral soft tissue is also affected. Oh, and there's an arrow there in the right femur. Looks like the greater trochanter has some hyperintensity there, enhancement. PD fat set is hyperintense, and also that lot of enhancement, that axial post contrast with, yeah, it looks like maybe even abscesses. I don't know if that's the neuroforamina. Maybe it's extending into the neuroforamina. And this is, looks like for a biopsy, CT. Maybe there's some gas there, I think, in the sacrum. I don't know if it's post-biopsy gas. And the PET shows definitely a lot of uptake, also on the right side.
So what do you think this is?
It could be, I mean, infection, I think, but it could be TB or bacterial. Okay, this is bacterial.
Turned out to be, I think, Staph aureus.
Staph aureus.
Okay, Shiv.
88-year-old female with breast cancer, rule out MET. So it looks like there's an enhancing lesion in the right psoas muscle. Probably infection. Looks like an abscess. And it's hyperintense on T2 and stir.
Yeah, so that was a Psoas abscess, not a MET. It's central area of lack of enhancement. It's typical of an abscess. Okay, Thomas.
Symptoms: weakness in the lower extremities, sensory disturbance, bladder, bowel, sphincter problems, headaches, seizures. So there's a intramedullary lesion in the thoracic cord. It's homogeneous, T2 hyperintense. And there's no enhancement on post-contrast images. So it's cystic.
It's probably a hemangioma there.
Right. Yeah, I think we're catching the top of the lesion there. No enhancement on the lesion. So okay, the T2, there's a T1 non-contrast. So yeah, there's cystic structure at the cerebelloponticle. And yeah, so there's multiple T2 hyperintense lesions, like with either in the ventricles or in the edema.
Probably both.
Yeah, multiple. They look cystic.
Hydrocephalus.
Right. So the obstruction.
So this one kind of should give it away. Oops, shit.
Oh yeah, there's calcifications in neurocysticercosis.
There you go. And there are the muscles. There's the cysticercosis. So this is why Jews don't like to eat pork. Yeah, so that was neurocysticercosis. Here's another person. You can see the typical punctate calcifications, hydrocephalus, which you get with this. Kind of cystic collection throughout the neural tract here. And again, very abnormal signal here. You don't see the nice thin nerve roots coming down like you normally see. A lot of diffuse meningeal type enhancement. This is just what it looks like in the gross. These big cysts that come out here. And then you can take out the little cysts themselves, and this is what they look like in a jar when you put the little cysts there. Neurocysticercosis. Okay, so who's next?
I think it's me.
You?
42-year-old Hispanic male. And we have a large cystic lesion in the right cerebral hemisphere. Looks like there's effacement of the right ventricle, midline shift. And we see some enhancement along the dura on the right side. Is it another neurocysticercosis? Yeah.
Okay. So why don't we move now outside of infectious diseases and go into spondyloarthritis.
Sorry, yeah. I'm just trying to see. There's a lot of stuff that we saw that looks like could have been mass metastases in the bone, in the spine.
Where?
Well, some of the stuff we saw, there was like some imaging overlap, I would think. But
where?
For instance, the one with the sternum, a lot of soft tissue, a lot of bone marrow replacement. I have a specific question about that. If we see the loss of,
like this one?
Yeah.
Yeah, but if this were a mass,
yeah,
it would destroy the end plates.
That's what I was going to ask.
The end plates are maintained here, right?
Exactly.
So this is characteristic of an infection.
That's what I was going to ask.
That's why I pointed that out. That's right. Very important.
Good. So there's no mass that'll act like that on T1 versus T2.
Not that I know of.
That's good.
Okay. So we'll talk about ankylosing spondylitis, reactive arthritis, which used to be called Reiter's syndrome, but that's a bad term now, since Reiter was one of Nazi physicians who was intimately involved in research during the Holocaust. So it's best not to use that term. It's called reactive arthritis, psoriatic arthritis, inflammatory bowel disease, and undifferentiated spondyloarthritis. The imaging findings we'll talk about are Romanus lesions, Anderson lesions. Neither of these are very specific. Ankylosis, insufficiency fractures, Syndesmophytes, arthritis of the costovertebral and facet joints, and enthesitis. Those are kind of the characteristics findings in this group called spondyloarthritis. And a lot of these overlap with degenerative disease, so you have to be careful with that. Forget this. Okay, so what are the things that we'll be looking for is sacroiliitis on MR. And this is a working group really primarily out of Canada that came up with criteria. These criteria are not really very good. If you look for bone marrow edema, which is really subchondral increased signal intensity on PD fat set or other fluid sensitive images, and it's not always edema. It's called bone marrow edema on a lot of the literature, but often it's not edema. Often it's just replacement of the marrow fat with inflammatory cells, and therefore you don't have to have true increased fluid in the interstitial spaces. So I don't like this term bone marrow edema, but it's throughout the rheumatologic literature in this particular area. But you need to see, to make the diagnosis of sacroiliitis, you need to see increased signal intensity in one region on two adjacent images. Again, this assumes you use their protocol. Basically, you need to see at least one lesion that's a centimeter or more in size, or two regions that are smaller than that. And then if it's in the periarticular, intra-articular region, it improves the diagnosis. But this is a very arbitrary classification, and it's in the literature. But basically, to call it sacroiliitis, you really need to see more than just a minimal degree of disease that looks degenerative. So the characteristics of back pain caused by inflammation tends to be onset less than 45 years. This number really comes from the days when people were making this diagnosis using plain films. So people would say if you have abnormals on a plain film and you had to be under 45 to consider the term ankylosing spondylitis. In actuality, most people with ankylosing spondylitis present in their teens. And if you wait till age 20, you've waited too long to make the diagnosis. So this is really should be considered a diagnosis of teenagers. The durations should be less than 3 months. It should have kind of an insidious onset, not induced by trauma. It prominently has morning stiffness associated with it, tends to be improved by exercise, not improved by rest. And the pain improves after arising, and it can be alternating back and forth with buttocks. That's what the clinical findings are. But the bottom line is, you should think about inflammatory back pain in young kids, and then in anyone who comes in who you don't see an obvious degenerative lesion with. Still, the vast majority of people with back pain are going to be the kind of back pain we talked about before, which is really degenerative disease, and now we know that also starts in the teenage years. So just because someone's a 20-year-old does not mean that they don't have disc disease and facet disease as a cause of their back pain, because this starts very early on, especially if they're athletes with contact sports. So ankylosing spondylitis is the big one here. It's really important now because this is a treatable disease. It was not a treatable disease back when I was in training. Therefore, we like making the diagnosis because it was kind of a sexy diagnosis, but it didn't really mean a lot because you really couldn't treat it. Now we can. Just 1 second here. Okay. So the diagnosis for ankylosing spondylitis, you should see sacroiliitis. It's very common in these patients on imaging plus one of the clinical features, one of the or HLA-B27 positive plus 2 spondylitic features, and age less than 45. And again, if we make the diagnosis more than in the late teens, and we're really missing that critical point where you can treat it. By the time these people tend to get in their 20s, they have irreversible changes and will go on to back pain even if it's properly treated, though it still should be treated. But think of this as a disease that we should be making in the teens. These are the spondylitic features. Clinically, inflammatory back pain, if they have arthritis, if they have heel enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease, if it responds well to NSAIDs, if they have a family history of the disease, HLA-B27 and elevated CRP, and there are a bunch of other serum studies that you can do now looking for antibodies that can also be helpful, about probably at least 50 of those now that some people use. In this particular study, they looked at imaging findings, and MRI can detect the sacroiliitis up to 10.5 years before X-ray. So if the initial diagnosis is made by X-ray, we've done a bad job. Because once you have X-ray changes, you have irreversible disease that you can stop, but it's already gotten to the point where the patients are going to have a lifetime problem. So we should always make the diagnosis long before the X-rays become positive. So what are the kind of things we look for? One is romulus lesions. These are these shiny corners or areas of replacement of fat, or what's called bone marrow edema, or really these are areas of inflammation on these anterior margins here. And this is very typical of ankylosing spondylitis. You get the inflammation here first. That helps with the development of the Syndesmophytes, which go on to fuse the spine. The Syndesmophytes are often difficult to see on an MR because the Syndesmophytes are black and the anterior longitudinal ligament is black. So we typically can't see the Syndesmophytes until after they're really chronic and they start developing fat and marrow space within them. But what MR does is it picks up the inflammatory changes here, and these are multiple levels. It's just along the anterior margin, and notice that the end plates where we normally see disease, except for this level, the end plates aren't bad. It's really concentrated on the anterior corners here, and it can also be at posterior corners. When you see that in a young individual with an MR scan, you should immediately think of ankylosing spondylitis. And Should have worked up. So here are the plain films. You can see the nice Syndesmophytes here on the plain films, the thin line here. And then later on, you can actually see the fat growing into the marrow space here. But again, on MR, we should make the diagnosis before the Syndesmophytes form. Because once they form, we're developing irreversible disease. You've got limitation of motion of the spine. So we want to stop the disease before it gets this far along. So this is late disease. In the old days, we would call this early disease, but not anymore. And then there are Anderson lesions, and they're basically small nodes. In this case, probably trauma from activity, and then the body doesn't heal properly because of the underlying disease, and you get these exaggerated small nodes and in-plate destructive changes, which are in the inflammatory world are called Anderson lesions. And acute Anderson lesions are basically a type 1 motic change where we have little swirl nodes associated with them. But again, these are in people with inflammatory disease. Multiple studies have shown you can't differentiate these from typical motic type changes seen in degenerative disease, especially in older individuals. If you see it in a teenager, then you immediately have to be concerned about inflammatory disease.
That's all the same. That's all the same patient.
These are all different patients.
All different.
Oh, this is all the same patient.
How is it? There's no. What is that on the way right?
Yeah, these are just different techniques.
Okay. Oh, I guess it's the stir.
This is probably a T1 fat set. This is a stir, and this is a T1. Yeah. Okay. And then here are areas of discitis where you're really getting destruction of the end plates, which is also a more prominent form of Anderson disease if it's due to inflammatory changes. So who was the last person?
I think it's me.
Okay.
14-year-old male with back pain. Okay, we have edema in the paraspinal muscles from probably L3 down L5, and also some facet edema. Yeah, there's another one up there.
Some bone edema there.
Yeah.
So what are you concerned about here? It's a 14-year-old. We can see that we already have some degenerative disease at 5'1". But these paraspinous inflammatory changes,
yeah, like ankylosing spondylitis.
really axial images, and notice you're around the facet joint and all this inflammatory change around the facet joints here.
Some inflammatory arthropathy.
And then there's the sacroiliac.
Yeah, sacroiliac joints. We see that there's kind of like fusion or not, but there's like fatty replacement and edema of the sacroiliac joint.
Okay, so this is these are
PD.
Really fluid-sensitive images. So we see extensive, quote, bone marrow edema, or this would be extensive bilateral sacroiliitis. So we have sacroiliitis, and you can see it's on both sides of the joint space here.
Yeah.
It's certainly more than 1 centimeter lesion or 2 subcentimeter lesions on different images here. So this is a severe sacroiliitis, and oh, that's right. This is just a study to remember. If it's in a postpartum female, realize that it's very common for women to get injuries to the sacroiliac joints during childbirth. So just be aware that they can look the same. But this is ankylosing spondylitis. And 13-year-old male.
Okay, so 13-year-old male with low back pain. Again, we're seeing extensive edema within the bilateral sacroiliac joint.
Both sides here.
Right.
One side over the inside. And then here are the coronal images.
Also, we're seeing the low single intensity along the both sides of the SI joints. Probably
so
edema.
This is another patient with ankylosing spondylitis. So again, at 13, most of these changes are reversible. If you stop the disease here, then this patient can go on to a normal spine. So it's really important to make this diagnosis. And then still, a lot of clinicians don't think of this diagnosis. A lot of clinicians think of ankylosing spondylitis starting in the 20 and 30-year-olds. They don't think of it in teenagers. And that's because in the old days we couldn't make the diagnosis till they'd had it for 10 or 15 years. But by then you've got irreversible changes that will go on, just progress on to destructive joint disease and degenerative disease. So just remember, this is a disease that we should be making a diagnosis of in the teenage years. Okay, this patient was sent in for sacroiliitis.
How old is this patient? It's an older patient, huh?
Yeah, not in their teenage years.
Well, there is subchondral kind of increased signal, eburnation, maybe cystic change in some areas. So
this is more cystic changes. This just isn't kind of diffuse edema.
Yeah.
This is really some structural loss here. This is some some degenerative disease in the spine.
Exactly. The spine.
This was a patient with ankylosing spondylitis as well. But unfortunately, we didn't make the diagnosis early enough in this individual. But still, this is better than waiting till they ankylose the SI joint. Okay, Pablo.
So this is an 18-year-old male, negative hip aspiration for infection, HLA-B27 positive, CRP positive, Evaluate for left hip pain. And there's edema of the femoral head and the acetabulum. There's some fluid too, looks like joint effusion. I don't see, in T1 there's hypointensity, but the shape is pretty much maintained there. So, and also the SI joint, I'm not sure on the right side if that's partial volume or there's some fluid there, edema and T1 hypointensity. So I guess it could be, again, a sacroiliitis with, in this case, left hip arthritis.
Yeah, we're not really in the sacroiliac joints very well, but on other images, this patient did have, well, I think I have some more images to show you. So these
sacroiliitis.
Also notice that there's a little valgus deformity of the hips on both sides too. So here's another.
So this is an SI joint plane, and looks like there is an erosion there or cyst, and on the sacral side on the right, and this axial views looks like there's fluid in the joint, and that we can see that cystic component. I think there's a PD fat cell on the right side in the sacrum.
Now,
and in that T1 has some fat around it.
So these are both abnormal. That's abnormal, and this is abnormal. You initially will get, it's just like we talked about with modic changes in the end plates. You'll initially get replacement of the fat by inflammatory cells. With modic case, it's an end plate injury. In this case, you get replacement of the normal marrow space here with inflammatory cells. That tends to burn itself out, and then that's replaced by fat. So what you'll see with chronic sacroiliitis, this is normal on this side, you'll actually see replacement of the marrow space with fat in areas where you had prior inflammatory disease. So just remember that, and then we see some eburnation along here, but this is evidence of long-standing sacroiliitis on the right side.
So this would be too late of a diagnosis?
Well, it's later than we would like. You still want to treat it to keep it from progressing further with inflammatory disease, but this is again someone with ankylosing spondylitis. And then here we can see a patient with very nice syndesmophytes here on the plain films. Can't really see the syndesmophytes very well at all on an MR examination. What we see are the shiny corners that should make us suspicious. Again, most early degenerative changes are here in the center. When they're on the edges like this, then because these are Romulus lesions, be concerned about the possibility of inflammatory disease. To be honest with you, if I just saw the MR scan here, since this is only at one level, I wouldn't be as suspicious as maybe I should, even though this patient has long-standing ankylosing spondylitis because the patient already has syndesmophytes which have formed.
Dr. Bruce, how do you differentiate syndesmophyte from ossification of the anterior longitudinal ligament on that plain film?
What syndesmophytes are ossification of the anterior longitudinal ligament. That's what syndesmophyte is. That's how it's different from an osteophyte.
Okay. So isn't it protrusion of the elected corners and extension of the bone marrow? Isn't it like an
Then eventually, if you have long-standing disease, you can actually get marrow extending into this.
okay.
But see, this are vertical ossifications which go along the anterior longitudinal ligament versus degenerative osteophytes which extend out like this because of the disc bulge produces traction injuries at the annular insertion here. The body tries to heal it and develops bone growing out in this direction. This is actually inflammatory disease that involves the anterior longitudinal ligament, which leads to ossification of the longitudinal ligament.
Okay.
And that's why it's so nice and thin, and that's why it's so difficult to see on an MR scan. Okay, say, Shiv, what do you think of this case?
33-year-old man, back pain, rule out disc herniation. So it looks like we have erosive changes of the sacroiliac joints bilaterally, fair amount of edema.
So we're basically showing more severe ankylosing spondylitis. This is a 33-year-old. This diagnosis should have been made 20 years earlier, so you would have stopped it before it got to this stage. And here we can see the extensive erosive changes of the SI joints. And again, you're going to treat this patient, but this will go on most likely to ankylosis. It's way too late in the diagnosis. Extensive erosive changes here in this patient with ankylosing spondylitis. Thomas.
19-year-old male treated by orthopedis for 2 years, low back pain, now 3 months of bilateral hip pain. So the SI joints, the distance is a little bit increased, which can happen in early sacroiliitis.
Yeah, maybe there's a little bit of irregularity here and loss of the density. Still looks fairly smooth here. Okay, so that's the plain film. Here's the MR.
Right, so MR, there's bilateral sacroiliitis with edema, and there's also inflammatory changes of the hips bilaterally.
Yeah, and the hips are also a fairly common target point for ankylosing spondylitis, but here clear-cut sacroiliitis on both sides. And this was ankylosing spondylitis in a 19-year-old. And people just don't think about it because we see so many patients with typical degenerative disease, but if they're teenagers, then you've really got to. You can have degenerative disease in teenagers, we know that, but the first thing you have to do as a radiologist when you image a young person for back pain is you've got to think about ankylosing spondylitis because that's treatable and it's really important to make the diagnosis early. Okay. Alrighty. Here's just a later example of bilateral sacroiliitis with erosive changes and edema. Again, bad disease. And then you can go on to fusion. Here is typical fusion of the sacroiliac joints on both sides. Ankylosing spondylitis. And then here we just, it's again hard to see, but these are all Syndesmophytes here. And this person's gone on to degenerative disease of the spine. This is someone with long-standing ankylosing spondylitis and also fusions of the facet joints back here in the posterior elements as well. The coronal images show fusion of the SI joints on both sides and a hip replacement on the left. So this patient was very stiff. Not a good yoga candidate. Okay. Let's see, why don't we stop here and we'll start here and finish up inflammatory disease tomorrow. Okay?
Thank you.
Thank you.
Thank you.